Obstructive sleep apnea is being increasingly recognized as an important cause of morbidity and mortality across the globe. Obstructive sleep apnea is a serious sleep disorder that happens when a person's breathing is interrupted during sleep. It affects almost 1 billion people globally, with prevalence exceeding 50% in some countries, especially the USA, China, Brazil, India, France, and Germany. Insomnia is a sleep disorder that regularly affects millions of people worldwide. A person with insomnia has difficulty falling asleep or staying asleep and may consistently wake up too early. In this episode, we present clinically focused insights from the experts with respect to obstructive sleep apnea and insomnia, and the emerging therapies, controversies, and uncertainties in obstructive sleep apnea and insomnia management.
Hi everyone and good day. I'm Sujit Rajan, consultant pulmonologist at the Bombay and Bhatia hospitals in Mumbai, and I welcome you all to Season 2 and Episode 7 of Healthcare Superstars. In Season 1, we had seen some amazing cases, as you all know: interstitial lung disease, COPD, asthma. In Episode 7, based on audience demand, we move into another very important concern area in respiratory medicine, and that is sleep-disordered breathing and insomnia. In today's episode, we shall be discussing 3 cases related to the diagnosis and management of obstructive sleep apnea, as well as a case on insomnia. And before I move forward with inviting our speakers today, I would like to first thank our collaborators, which are the Sri Lankan College of Pulmonology, the Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM, and AFMAPATH from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, Panama Pneumology Association, and the Yemeni Association for Respiratory Care. So, to introduce our first speaker for today, Dr. Nancy Collop. Nancy, MD, is Professor of Medicine and Neurology in the Department of Medicine and Neurology and Director at the Emory Sleep Center, Emory University in Atlanta in the United States. Nancy has been awarded the Best Doctor of America and is Editor-in-Chief of the Clinical Sleep Medicine Journal and Up to Date. She's the study coordinator and principal investigator in 17 clinical trials and has written 2 books and 50 chapters and monographs on sleep medicine. Nancy has over 80 peer-reviewed publications and has been invited for over 60 national and international lectures on sleep. I was introduced first to Nancy at the American Board Review course last year, and she gave some outstanding talks there. So welcome, Nancy. Our next speaker is Dr. Emerson Wickwire. Emerson, MD, PhD, is the Associate Professor in the Department of Psychiatry and Medicine at the University of Maryland School of Medicine in the United States. Emerson is also the immediate past president of the Maryland Sleep Society, US, and the editorial board member of 4 sleep journals. Emerson is also study coordinator and principal investigator in 10 clinical trials. He has written 7 chapters in different scientific books on sleep medicine and over 140 peer-reviewed publications. Emerson has also been invited for over 65 national and international lectures on sleep medicine. So welcome, Emerson, today. And so we will start with our cases very shortly.
Thank you. So the first case is EP, who is a 68-year-old with COPD who needs a total hip replacement. She notes snoring and poor sleep when she's being evaluated for her hip replacement, and an Epworth Sleepiness Scale score of 9. And she's noted to, in addition to her COPD, have comorbid hypertension. Her most recent spirometry is seen here. She has, as you can see, mild obstructive lung disease with no significant response to bronchodilators. So a polysomnography is ordered, and the baseline data on the polysomnography shows she has very quite frequent apneas and hypopneas with the apnea-hypopnea index of 128 events per hour. Her lowest oxygen saturation is 79%. And she actually spent a good amount of the time during the sleep study, the baseline portion, with her SAT below 90%, 42.7% of time during the baseline portion of the study with a low oxygen saturation. So it was performed as a split night study. So the second part of the night, they put her on CPAP and a titration occurred. And at a CPAP pressure of 10, they were able to drop her residual sleep disordered breathing index to 3.4 events per hour. Now here is a picture of her sleep study. We call this a hypnogram. And to just take you through this briefly, the top box here is sleep. And so wake, REM, non-REM level 1, non-REM level 2, non-REM level 3. The next part of the hypnogram shows body position. So start out on her back, move to her right, a little bit of time on her left, and then to her back for the rest of the night. As I noted, this was a split night study, so she was put on CPAP at this point, and you can see the progression in CPAP pressures. This, of course, is her oxygen saturation, starting at 100 down to 60%. Heart rate, snoring, you can see there was some snoring going on pre-CPAP, and the breathing events. So the predominant number of breathing events were obstructive hypopneas, and you can see those here. The other thing I want to point out is, as I mentioned, she had a lot of oxygen desaturation, both associated with hypopneas and even kind of a low SAT in general, probably due to her underlying lung disease. And then you can see as the CPAP pressures increased, the degree of oxygen saturation improves, and when she gets over here to the pressure of 10, her SAT is much improved, and there's no longer any obstructive breathing events.
So Nancy, if we can just go back to that last slide, a lot of respiratory physicians look at these hypnograms. Actually, a lot of respiratory physicians look at oxygen saturation in the AHI. So do you think there's something more we should be looking at besides oxygen saturation and AHI, which seems to be what a lot of us are obsessed with in this hypnogram? And how important is it for us to look at these hypnograms?
Yeah, I think, so when I get a sleep study from an outside provider, it's the first page that I look at, because the narrative page that will give you the AHI, sure, but it really doesn't give you the whole story, right? So the AHI is obviously, I'd like to see when the events were occurring. And in addition, you'd like to see what type of oxygen desaturation they're having with these events. So again, for this particular patient, and the other thing I would mention, and this will come up more as we get to the second case, you want to see how many different levels of sleep did they go through on the baseline. So as you can see, one of the problems with split night studies is that if a patient has severe apnea, you want to get them on CPAP and get them titrated. But what will often happen in a split night study is they won't go through REM sleep. And so you can see she does have a REM period here. This is the black thick line here, but she doesn't have REM in the beginning. And so you would suspect, based on her severe sleep apnea and her underlying lung disease, that in REM she would have done even worse. So I think those are the highlights that you can look at on the baseline. And then obviously, as I said, in her, while she doesn't actually have that, what I would say, severe oxygen desaturation, because, sometimes we'll see saturations go into the 60s and 50s and even lower sometimes. She has consistent oxygen desaturation, but she's kind of hanging, her desats are kind of hanging in the 80% range. The other thing I'll point out is, over here, when she's on CPAP and REM, you can see she actually does pretty well. I had to split the screen so you can kind of see the whole thing together. But she does have a few hypopneas over here in REM, and that kind of precipitated the increase in pressure. So you want to make sure, ideally on a CPAP titration, that they go through REM sleep to make sure you've gotten the optimal level of CPAP.
Please go ahead.
Okay, so she gets put on CPAP. She has her hip replaced, and as often as the case, she has some struggles with the CPAP, but she agrees to use it and has to change her mask a few times, but she finally finds one that works. And she comes back to clinic after she's been on the CPAP for 3 months. Her oxygen saturation in clinic is, on the lowest side, but okay, 93%. Her Epworth is a bit better, improved by 2 points. And if you look at her CPAP adherence data, she missed 3 out of the 90 days, but her average use is 5.5 hours. There's not much leak from the mask currently, and the residual AHI is at 2.8. So you feel pretty comfortable that she's doing okay on her CPAP.
So Nancy, one more thing on that slide was excellent compliance. I mean, pretty decent compliance. Yet, I noticed that, her pressure requirement is 10 centimeters. Now, this is a little odd. We've normally seen high AHIs, higher pressures. Any thought there?
Yeah, so I think in this particular case, remember, she has kind of borderline oxygen saturation. She's kind of hanging right on the curve of that oxygen saturation drop off.
Sure.
And what you'll see a lot of times is people have, particularly people with lung disease, will have maybe a high AHI, but not that, as you noted in the slide before, not real severe oxygen desaturation. So she has a lot of events with narrowing of her airway and drops off that 4% quite frequently.
Right.
Really, she doesn't require a lot of pressure to keep her airway open. And, it's kind of average pressure. So, so I think it has to do in this particular case because of her underlying lung disease.
Lung disease. That's what I was thinking. Probably the underlying lung is the larger reason for that lower pressure requirement. Please go on, please.
Okay. So she gets her hip replaced. She kind of gets lost to follow up, but comes back 4 years later. And her lung disease has progressed in such that now she's having to use oxygen during the day at 2 liters per night. 2 liters per minute. And so we go ahead and get her CPAP data from her machine. And this is a picture of her download. Now it's a lot of data to digest.
Right. Can you explain it as simply as possible? Because I find it a very complicated slide, but for our audience.
It is, but I guess for me, having looked at thousands of these over my life, it's like, oh yeah, that looks great. So I'll take you through it very quickly. So on the first page, I kind of put several pages together. But on the first page is the hours of usage. And so each bar represents a 24-hour period. So for example, if a patient would sleep 5 hours one night and take a 2-hour nap, it's going to show up on here as 7 hours.
Sure.
So this is cumulative sleep time. And the black line here is 4 hours. So in the US, insurance companies require that patients use their CPAP at least 4 hours or they'll take it away from them.
Sure.
So this black line is there. But in her case, you can see she does pretty well. And so most of her bars are green, which means that she used it at least 4 hours every night. She does have one red bar, which means that particular night she used it less than 4 hours. And then there's one where a bar is missing, which means that night she didn't use it at all. So again, pretty good use and probably pretty consistent with that 5.5 hours she was doing before. When you go to the next page, you'll see actually when they put the machine on and when they take it off. And so it gives you, hours down here, hours of the night or day. So 0 being midnight. So, she's consistently putting it on around midnight and waking up around 6 or 7 in the morning. This night she put on a little early and then had an awakening and stayed awake for a while and then put it back on. And this fraction over here is the amount of time that the machine was on and at pressure divided by the amount of time the machine was running. So you can see most of the time it looks like she put it on and wore it all night and never took it off. There's an occasional one where there might be a minute or two here where, maybe here you can see there's a little black line there. So that means that she was wearing it, she got up, maybe used the restroom, kept it running, and then put it back on and it was back at pressure. So it's, 618 over 621. Just took a couple minutes, left the machine running. So that's that. And this is very helpful to kind of see, it's almost like an actigraphy. You can kind of track patients' time that they're using the machine, if they're taking naps, if they're night owls, all different kinds of things you can glean from this. Very helpful at times. The next page on the report just gives you information about how well the machine is functioning and what the pressure settings are. So her pressure is at a fixed pressure of 10. So you can see she's on 10 all night long. And then the machine has a flow sensor in it, and it tells us how often the patient's having any breathing interruptions. And so again, this is across that 90-day period. Each little section here represents 1 day. And overall, she's doing quite well. She's having, no periodic breathing. She's not having she's having very few apneas, occasional hypopneas, RERAs. And then this even looks at snoring and flow limited breathing. That's what FL stands for. So over this 90-day period, the machine estimates that her average breathing index is 2.4 per hour, which is similar to what she was when we saw her 4 years ago. So what we aim for this number to be is less than 5 per hour. And then the last page of this report gives you information about leaks. So if the mask is leaking, you'll see some data here. You can see she has very little leakage from the mask. And then this is information about her humidifier settings.
What is an acceptable leak?
This is a really nice summary, and in this particular case, a very adherent patient. There's lots of information that you can glean from these reports, and I would encourage people, if they can get them, to look at them.
And what would be an acceptable leak when you look at the leak graph?
Yeah, so the way this is a machine that's made by Philips Respironics, and what they will call an acceptable average percent leak is less than 10% per night. So just going back, remember, she's lost the follow-up. She's using her PAP, and we can see it looks pretty good. She's on oxygen during the day now. And so it looks like this all looks great. So what would you do next? Would you do anything different, or just say, you're doing great, see you later? So the CPAP information is great as far as looking at disordered breathing events, but it doesn't inform you at all about oxygen levels.
Sure.
And as you know, as a pulmonologist,
Right.
that sleep can be a stress test for people with lung disease, just like exercise test might be. And so, in cases where we know patients have hypoxemia, it's always worthwhile to check an overnight oxygen test on them, particularly in this case where we know her oxygenation has definitely gotten worse over time. So we ordered an overnight oximeter on her while she was wearing her CPAP machine. And so here's the result. And you can see she has pretty dramatic oxygen desaturations during the night, even while on CPAP. So at this point, you have a couple options. You might bring her back into the lab, which probably most people would do, just to monitor her and see if CPAP plus oxygen alone is going to be appropriate, or may benefit from non-invasive ventilation.
Sure. And when you bring them back into the lab, Nancy, do you actually check the flow rate the whole night? You have your technician checking the flow rate every night, or you just set it at 1 liter per minute and get your data the next morning?
Right. We would bring them back and do in this case, probably do a full polysomnography on them and have the technician dial up the oxygen as they need it. In her case, even though she has a normal bicarb, I might put a transcutaneous CO2 monitor on her and monitor her CO2 through the night as well.
Sure. So those are rarely available, at least where I work, and they're expensive.
Even in the US, they're not consistent.
Okay, because we would think that if the oxygen saturation is dropping, the overnight oximetry is a simple test, but we would wonder whether we have to get the patient back into the hospital for that. Can't that be done at home in situations where you could just get a simple NITOX machine or something like that?
Yeah, I think in this particular case, her oxygen saturation is pretty low. I mean, pretty dramatically low. I think in cases where the oxygen saturation may not be as severely decreased, you could simply just say, wear your oxygen with your CPAP at night at 2 liters per minute, and then repeat this test.
Emerson, any thoughts on this case?
I'd be very curious what the patient's subjective experience was, Nancy, over the course of time, how she was doing beyond simply the Epworth score and some of her respiratory parameters.
Yeah, she, as far as her sleep goes, she was feeling pretty good. I mean, she didn't really have any specific sleep complaints. I mean, obviously her respiratory status had gotten worse, and so, she had become less active. But she didn't really have any complaints about her CPAP at this point in time.
Nancy, how was she feeling during the day?
Again, I think more of her complaints were related to her respiratory status. So, she was not as active, as I mentioned, as she used to be, and maybe a little depressed about that. But she wasn't excessively sleepy or fatigued per se.
Great case. It really, to me, it highlights why we need such a granular approach on the respiratory care side, if you will, or on the pulmonary care side. From an interdisciplinary care team perspective, we need to be dialed into the medical numbers.
I agree, Emerson, I agree.
So just to summarize a little with regards to this case, when you look at the prevalence of obstructive sleep apnea, it used to be thought that it was higher in patients with COPD, but subsequent studies have shown it's about the same as an age-matched population. However, these patients will tend to have more hypoxemia, as I mentioned, much worse in REM sleep. They're obviously more likely to have cor pulmonale. Usually you can get away with just adding oxygen, but if they have that REM-related hypoventilation, they may need non-invasive ventilation with like a bilevel PAP or an AVAPS. And as we've talked about, the utility of overnight oximetry.
Yeah, I think most chest physicians seem to even today lecture that OSA is more common in COPD, and they love to talk about the overlap syndrome, and you're seeing recent data suggests that it's not more common, right?
It's not more common, but it tends to be, it's an important association to recognize, for sure.
Sure. That I agree with. That's great. Fantastic. Thank you so much, Nancy. Enjoyed that case, really, and please, over to your next case.
Okay. So my next case is a patient that was admitted to the hospital for lethargy that was noted by his family at home. They had trouble waking him up one morning, and so they brought him to the emergency department, and his oxygen saturation was 80%. And so he had a blood gas drawn, and you can see he has hypercapnic respiratory failure. And so he was admitted to the ICU and put on non-invasive ventilation. He was then diuresed and improved. It's notable that his BMI is 56. And so after that hospitalization, after that ICU stay, his blood gas improved. He remains a mildly bit hypercapnic, but his oxygenation is better now on room air with a PO2 of 60. And so in this particular case, prior to his discharge, they did a portable sleep test. Let me show you that on the next page. And then he was discharged. And and he wasn't given any oxygen or PAP therapy at the time. And this is not that uncommon.
This is very, very uncommon, I can tell you. How was he discharged? And why does this happen? Without oxygen, no PAP, with that study?
Yes, so if you go back, remember his oxygen in the hospital now is 60, so he doesn't qualify for oxygen in the US.
Okay.
So he's not given oxygen, and
but they don't do an exercise test to check whether he's desaturating on exercise, considering he's on the border.
Yeah, well, they could have.
Sure.
It's possible. There are ways that they might have gotten him to qualify, but he didn't get. And he was discharged. And it's really hard to get PAP therapy in the U.S. At time of discharge.
But they did a type 4 study before he left. A type 3.
Right. So they did try to at least to get, so once he's out, they could maybe get him on therapy. So so here's a copy. So this is a WatchPat device. I don't know how commonly it's used in the places.
Is it something like an apnea link, or is it?
It's a little bit different,
Okay.
but it does have the most important signal, which is the oxygen saturation, which you can
Right.
see.
Sure.
It actually scores breathing interruptions based on something called peripheral arterial tone
Okay. Yes, I've heard of that.
variability. So it uses an integrated algorithm along with the oxygen saturation. So this is kind of the most important panel. So it has an estimate of sleep, wake, REM, light sleep, deep sleep. And so, you can see it estimates right here, he's in REM. And then you can see the oxygen saturation while he's awake isn't bad. And then once he, drifts off into REM sleep, you can see there's some significant desats. He has a little awakening here, and then there's more REM. And then the rest of the night, when he's sleeping on his back, he has just recurrent oxygen desaturations. And so his overall AHI, based on this study, was almost 70. The oxygen saturation went to as low as 73%, and he spent almost 12% of the night with his oxygen saturation less than 88%. So this patient likely has obesity hyperventilation syndrome. Of course, that's defined by a BMI over 30 and a wake PCO2 over 45. And it's a diagnosis of exclusion, so you want to make sure they don't have other disorders that may be causing the hypercapnia. Most of these patients will have some abnormal lung function. Some of them may have developed pulmonary hypertension. The vast majority of them will have sleep apnea. And unlike obstructive sleep apnea, it has a similar prevalence in both females and males. Obesity hyperventilation syndrome has varied pathophysiology, which obviously starts with the fact that they are morbidly obese. They have impaired respiratory mechanics because of their obesity, increased work of breathing, and as I mentioned, most of them have sleep disordered breathing, both obstructive sleep apnea and sleep-related hypoventilation. They are thought to be leptin resistant, so they actually have high leptin levels, and that probably contributes to a problem with their respiratory drive. They may have trouble with respiratory muscle endurance because they have to work so hard to breathe all day long and all night long. And as mentioned, with the sleep disorder breathing, they can get hypoxemia and hypercapnia. Ultimately, these patients end up having low ventilation and hypercapnia, which occurs both at night and during the day. So going back to our sleep study the patient had, as I mentioned, you can see he has this little bit of REM period, a little tweak of REM here, and then goes back to non-REM sleep and then more REM. And you can see these spots right here are very important. And this is what I alluded to earlier, but this is kind of a combination of sleep apnea and REM-related hypoventilation. So sleep apnea causes this sawtooth pattern like you see here. Repetitive oxygen desaturation, resaturation. So these are probably repetitive breathing events, obstructive breathing events. But what happens in REM is they're still having the obstructive breathing events, as you can see here. So there's still some of that sawtooth pattern, but the oxygen saturation is continuing to go down. So they don't recover from the baseline. And, you know, if you were measuring their CO2 at this time, you'd see that the CO2 is probably going up as well. So they have this REM-related, both obstructive sleep apnea and REM-related hypoventilation.
That's fascinating. I think that's such an important point to take home.
So he does get back and has a PAP titration in the sleep lab. And most of these patients will do just fine with CPAP, but in this particular case, he was placed on bi-level to start. I wouldn't necessarily recommend that, but that's exactly what happened. So as you can see, again, getting back to the hypnogram, so he has a few, it doesn't show up very well, but he's having some hypopneas down here. And again, he starts right out in REM sleep. So he starts in REM, he goes right into REM sleep, which is often what you'll see when patients have severe sleep apnea and they go to sleep for the first time with a PAP machine on. It's like, oh my, let's right into. And so they start out with a pressure of, it looks like 12/6. And he goes into REM, and you can see here's that 90% line. So immediately he starts to hypoventilate again and having events just like we saw earlier. So they go up on the pressures, and they get him up to a bit higher level during that REM period. And you can see now he finally starts to have improved ventilation. And then fortunately for us, back over here, he goes into REM again, which is really helpful. And you can see now, you know, there's a few maybe events still going on, but he's now maintaining his oxygen saturation at acceptable levels.
Fascinating. The amount of information. Just to understand again, the watch pat also made out he was in REM or didn't have that information?
Yes, I'm gonna go back. The WatchPat device itself has an algorithm that distinguishes wake, REM, light, and deep sleep. Now they're not measuring EEG, okay, but it's actually a pretty accurate algorithm, about 80% of the time. And oftentimes the REM is pretty obvious, like it is in this particular.
So that's a little bit of an advantage.
This is in a polysomnogram, so we know these are REM periods.
But the WatchPat, that means, has that little advantage over the apnea link in determining that.
Yeah,
right.
Yeah, it does give you a little bit more information on sleep staging.
That's good. Super.
So, you know, with regards to obesity hypoventilation syndrome, if you take sleep apnea patients and match them by age to obesity hypoventilation syndrome patients, we know that those with OHS will have a lower quality of life, they have more healthcare costs, and they're much more likely, as I mentioned, to have pulmonary hypertension. They also tend to end up in the ICU more, and they tend to need mechanical ventilation more. If there's one point that, you know, I could make, this is an old study, but it's held up over the test of time. And if you can discharge these patients on mechanical ventilation or on non-invasive ventilation or PAP therapy, you reduce their mortality substantially. And so this is comparing patients with just simple obesity versus those with obesity hypoventilation syndrome that were hospitalized. And you can see those that did not get mechanical ventilation were much more likely to have a higher mortality.
Sure. Also, a lot of these patients just get NIV when they get discharged. And then of course the studies come later when they need specialist evaluation. They're often seen by internal medicine colleagues. They're put on an NIV. None of them are interested in doing a sleep study, and they go home with the NIV machine. And then when it comes to stopping the NIV or understanding it better, they land up in pulmonology clinics, and I think there's a lot in this data that we can learn from.
Yeah, so there's been a lot of study around whether OHS patients need CPAP or need NIV.
Right.
And most of the studies show that CPAP is fine for the vast majority of them. If they have significant oxygen desaturation or that REM-related hypoventilation, some of those patients will benefit from NIV. But interestingly enough, even after like 3 months of therapy, a lot of them don't need the NIV any longer. They can go back to regular CPAP. But like I say, most of them just stay on the NIV because it's tends to be a little more tolerated and more comfortable for them.
And often they've bought the machine, so I guess the NIV machine can be fixed on a CPAP pressure as well, right? So
it could be. It's not going to probably hurt them to stay on NIV either. So I would say anything that makes them use their machine more is beneficial. So keep it on the NIV setting is probably okay if they purchased it and they're using it.
But I think far more patients than necessary get NIV rather than CPAP with OHS. So what percentage of patients would you say, Nancy, would do well with CPAP who have OHS?
I'd say 75-80% would be what the literature would support.
That's a lot. So there's a lot of NIV patients or NIV machines making good business there, but probably not actually indicated. That's very, very interesting. And CPAP machines are much cheaper than NIV machines. So I think that message should get across to pulmonology practices across the world. Please, Emerson, your case, we are just looking forward to interact in understanding this case and interacting on it.
So what we'll do with this case is slightly more didactic, primarily because the audience, our audience today, is likely going to be much less familiar with some of the background surrounding insomnia and lifestyle change or cognitive behavioral kinds of treatments to begin with. So let's start really with two overview facts. First, insomnia is very, very common in patients with obstructive sleep apnea. In fact, and these data are now over 20 years old, but even among the stereotypical obstructive sleep apnea referral patient of the 1990s, in other words, someone with loud snoring, classically obese in the United States, they would be referred to an academic sleep medicine center several decades ago. These were patients who really very clearly were at high risk for obstructive sleep apnea. Even among those patients, there's still a prevalence of chronic insomnia of somewhere around 40 to 50%. And the literature has really been very, very clear. There are a number of potential physiologic mechanisms, which I'm happy to speculate about. Those data and the mechanisms aren't exactly clear, but certainly sympathetic activation is a major shared physiologic mechanism. The bottom line is that we used to think of sleep disorders patients in a very orthogonal way. These were obese patients with loud snoring who had obstructive sleep apnea, or these were kind of worried well, highly anxious patients with chronic insomnia. And over the past several decades, looking at data from the World Health Organization and the diseases globally that cost the most money, these always involve both a biological and a behavioral component. Think about obesity or smoking or cardiovascular disease and so on and so forth. So what we once thought was very clear either or, we now know is really much more complex and overlapping. When we talk about chronic insomnia, we simply mean trouble falling asleep, trouble staying asleep, or both. The frequency of insomnia is 3 nights per week for 3 months or more. in terms of the diagnostic criteria. And generally, we use 30 minutes as a threshold for what is taking too long to fall asleep, or how long am I awake in the middle of the night. So if my sleep latency exceeds 30 minutes, or if my total wake after sleep onset exceeds 30 minutes, those are pretty good clinical rules of thumb for taking too long to fall asleep or being awake too long in the middle of the night. Of course, insomnia needs to be associated with a daytime consequence. These consequences run the gamut from cognitive dysfunction to fatigue or sleepiness or irritability or depressed mood. Obviously, there's a very broad range of outcomes of insomnia. And as you mentioned earlier, it's really incumbent on the physician to connect the dots, because patients sometimes don't even realize that their sleep is a problem. The population prevalence of insomnia is approximately 10% globally, although there's some variability. And in clinical practice, the population prevalence of chronic insomnia increases dramatically, approaching 50%. So chronic pain and chronic sleep trouble are two of the most common reasons why patients go to see GPs to begin with. Insomnia is associated with worsened mental health and physical health outcomes across a very broad range of disease categories. Insomnia diminishes quality of life, and insomnia increases economic costs. The disease categories in which insomnia is highly prevalent and in which insomnia worsens outcomes are very important, because we know that we can improve insomnia in many, in fact, all of these that I have listed here. We know that we can improve insomnia in these chronic conditions to improve sleep, improve quality of life, and in many cases, improve outcomes in the so-called primary disease state to begin with. So when pulmonary physicians, when respiratory physicians see patients with obstructive sleep apnea, they should also be asking, how long does it take you to fall asleep? How long are you awake in the middle of the night? And so forth. The most common treatments, as you mentioned earlier, remain pharmacotherapy, sometimes liberally prescribed. And we'll talk about the data in just a sec. There's nothing inherently wrong with thinking about pharmacotherapy for insomnia. However, we know that behavioral therapies produce longer lasting benefits, and certainly all of the consensus recommendations from the American Academy of Sleep Medicine to the National Institutes of Health and the American College of Physicians and the British Pharmacological Society and on, they all recommend what are called cognitive behavioral treatments, or CBT, CBTI, for the long-term management of chronic insomnia disorder.
Emerson, before you go to CBTI, how bad is this problem in your practice? How many referrals from primary care are already on a drug?
Many. And this is problematic for two reasons, because oftentimes when a primary care physician, we can't ask primary care physicians to be specialists. And so primary care physicians can detect, and they often do, that sleep is a problem. But sleep, of course, to people on this call and to our audience today, is really an umbrella term. There are insomnia disorders and sleep breathing disorders and neurologic conditions and so many things in between. So primary care docs can recognize sleep, and often what they will do, because it's one of the few tools that they have in their armamentarium, is they'll prescribe a sleep medication. Well, if that patient had obstructive sleep apnea, and as we talked about earlier, half of them do, then now what we're doing is we are suppressing the arousal threshold in patients who are struggling to breathe at night. So comprehensive assessment and thoughtful diagnosis are just essential, right? Assessment, diagnosis, prescription. We need to follow all three steps.
Sure, absolutely.
So there are a broad range of medications and over-the-counter medications, and increasingly CBD and so forth. Each of these have different risk-benefit profiles, but I want to make sure to give a nod that this is the status quo.
Sure.
No pill can teach your body how to sleep, but an evidence-based behavioral treatment can. Part of the problem when we're talking about chronic insomnia, not necessarily all of the problem, but a large part of the problem, is that through repetition, our patients have learned how to be very poor sleepers. Practice makes permanent. And obviously, there's a strong behavioral component to our sleep routines. There are virtually no adverse side effects to behavioral treatments for insomnia, although during the so-called sleep restriction phase, which I'll explain in a moment, patients will feel sleepier, so we need to make sure that they stay safe while driving and so on and so forth. There are hundreds of clinical trials with moderate to large effect sizes demonstrating that CBT works. There's no question that CBT works in the majority of patients, including in many comorbid populations, as I mentioned earlier. This is a brief treatment, so this isn't a lie down on the couch and let's talk about childhood traumas. This really is a sleep-focused training intervention. And like many behavioral treatments, this has become increasingly manualized over time. And by manualized, what I mean is we want to make it paint by numbers so that it's easier for physicians or social workers or non-psychology professionals, non-behavioral professionals to implement these evidence-based treatments. Increasingly, there are online interventions and mobile phone interventions that are designed not only to make patients' lives better, but also to make physician practices and healthcare providers' lives easier as well. So let's talk about a case and use that as a starting point to expand our discussion. This is a 67-year-old male with primarily sleep onset insomnia, a BMI of 28, so he's normal weight, and he was diagnosed with mild, almost moderate obstructive sleep apnea. Past medical history significant for GERD and chronic knee pain, and no past mental health history. He takes an antihypertensive medication, and he also takes an over-the-counter sleep aid. As far as seeing patients in the sleep disorder center go, the patient is relatively unremarkable. He has chronic sleep onset insomnia and mild obstructive sleep apnea. This is a very common, presentation. There's some chronic pain history here. The GERD is of course very common in untreated OSA. Now, I want to highlight here where Dr. Collop's cases, where Nancy's cases really, I think, emphasize the importance of fine-tooth, laser-focused read on the physiology and biological signals, and even for that matter, diagnostic test results. Insomnia is a more subjective presentation. It's a subjective clinical diagnosis. There is no diagnostic test. And in this case, let's take a look at what the patient's really telling us. During the day, the patient notes that he's having cognitive difficulties. He can't focus as well when he goes hunting, which he does for leisure. He's almost falling asleep in his deer stand. He talks about his eyes feeling tired during the day. He works at a hospital, and he is a part-time shift worker. And when he is at work during his shifts with no immediate stimulus to keep him engaged, he tells me that he just wants to go ahead and doze off. One of the things that's most important to the patient is he knows that he is irritable with his family, and he's aware of it, but can't quite stop himself because he's so sleepy and much more reactive than he'd like to be.
These are such common symptoms of insomnia. We see it every day, but we never put down that detail. When the patient talks, we just feel he's just tired, but there's so many other small points that I relate to.
These are and I'd encourage our audience, these are the kinds of questions that, when it comes to behavior change, really matter. In fact, in just a sec, we'll talk about how I open all of my clinical interviews, and now I train physicians of all backgrounds in providing comprehensive sleep medicine care, and all of them report that learning how to conduct initial interview is the highest yield activity that they gain from rotating through the sleep disorder center. In terms of comorbid insomnia and sleep apnea, if you can't sleep, it's even more difficult to get used to CPAP than it was before. Earlier I mentioned that it's very important how you begin your diagnostic interview. And so with all of my patients, and I see patients with obstructive sleep apnea, chronic insomnia, circadian rhythm disorders. Those are probably the three most common disorders that I treat in my practice. And all of my diagnostic interviews begin the same way. And that is, if I had a magic wand, it could change anything about your sleep, what would you want that to be? And patients are generally a little bit stunned. And after they tell me they'd like more sleep or to sleep through the night, I ask them, how would your life be different? And for this particular patient, the way that his life would be different is he would be less snappy with his wife and family. And the reason it's so important to understand that is that I now know why the patient is here. And this is the carrot that I can then use to help motivate the patient to stick with some of the changes that may get worse before they get better, okay?
Fantastic. I think it's a wonderful approach.
In terms of putting together a treatment plan, one of the things that's important to understand about behavioral approaches is that they can really be highly personalized. So when we're talking about 4 to 6 sessions, some patients are 2, other patients are 9. We're really going to tailor our approach to exactly what's going on with this particular patient. Now, the patient, by the time they came to see me, had already failed at CPAP therapy, which of course makes my job a little bit harder, but it's going to be a very common experience for our audience, and that's why I thought this would be a useful case. This is a patient who knows that they have trouble sleeping. They were told they had sleep apnea, and they didn't want to have anything to do with CPAP. And behavioral treatments that focus on motivation are the currently most effective interventions to increase CPAP adherence. So what we do with this patient is we develop a combined approach. In this case, what the patient did was elect to begin with onset insomnia. And what I do, which I'll show you in the next slide, is begin to think about how can we get a win on the onset insomnia side and then add CPAP when the patient's ready. So questions to consider in a case like this are what is the pre-sleep routine and what is the bedroom environment? The bedroom environment needs to be cool, dark, quiet, and uncluttered. And what is the patient doing that may be activating his pre-sleep arousal, where it's causing him 60 minutes or more sleep latency each night? What's he thinking about? Are there real or perceived stressors where we might be able to make progress? What's his somatic activation? And what are the patient preferences? Is this a patient where we want to focus on a regimented approach and using behavioral language? Or is this a patient that is open to or interested in approaches like mindfulness or meditation or yoga, and I'm going to talk about treatment, treatment's not going to change necessarily, but the way I talk about treatment will change based on what that patient is bringing to the table. What are his knowledge, attitudes, and beliefs about CPAP? Unfortunately, most patients have not been well educated about CPAP or well supported about CPAP early in the course of care. And then what's his confidence to change? Does he think that he can do this? In this particular case, you'll see that sleep latency, it was taking the patient almost an hour. All of these data are based on sleep diary. This was a 6-session encounter, and patient's verbal report, sleep quality's gotten much better. CPAP use has increased. Unfortunately, the machine was old, and so we don't have any of the lovely objective information that Dr. Kolb showed, but the patient verbal report was that we were wearing CPAP now most nights 2 to 3 hours a night, which is an improvement from where we were. Patient verbal report is of increased daytime energy level, and just overall sleep satisfaction has increased. The patient is falling asleep faster. It was originally taking almost an hour to fall asleep, and now it's taking less than that 30-minute threshold. The patient is getting over an hour more of sleep each night. You can see that the patient used to be awake more than an hour during the night, and they're now awake less than 20 minutes. And the sleep efficiency has increased also within to the normal range. So this is a very common case for comorbid insomnia and obstructive sleep apnea, and I'm happy to answer questions.
I think that's fantastic, because I think comorbid insomnia in sleep apnea is just labeled as anxiety very often, and no one looks, very few people look into the aspects you have talked about, Emerson. I think it is so important. Some of the messages you've mentioned, and I can see so many letterheads, as I mentioned in the beginning, saying that you're a sleep specialist, but when the insomnic patient comes, you are clueless beyond a Z drug or a benzodiazepine, and sometimes melatonin, so, to make it a little milder. But Nancy, your thoughts as a pulmonologist, hearing this, what's your perspective on insomnia? I have a few questions that have come from across the world, so I thought I'll just have quick answers from both of you all over a few minutes. But your take on insomnia in a respiratory practice, do you think very neglected, somewhat neglected, or well dealt with?
Yeah, I think, I guess I'm a little biased because I see all patients with sleep disorders. So the insomnia patients that end up coming to me in my clinic are usually very challenging. They've had insomnia for years, and they've tried every different pill that they can think of, and they can be very challenging to manage. The cases like Emerson just presented, the sleep apnea and insomnia, those are, for me, a little bit easier to manage, in that a lot of the basic tenets of what he talked about, I will use with these patients. And what you find specifically with CPAP use is some of them, when you put them on CPAP, that cures their insomnia. So the insomnia is really related to the sleep disorder breathing, the interruptions in their sleep. And so, those patients will often get better, and just the CPAP is enough, and everybody's happy then. There's the population like Emerson described, where they have a lot of anxiety and fear about using the CPAP because they're not sleeping well already. And then, you try to need to work through some of your CPAP magic, trying to make sure they understand how CPAP works, and you try to improve their fear of it, reduce their fear of it. And then, there are many that, might still have some insomnia issues after they start CPAP. And on occasion, in those patients, I will I will try a hypnotic agent. There's some data that might help a subgroup. I don't usually try it. I mean, I tell them you can do this for a while, and sometimes that's enough to get them using CPAP and get them comfortable with it, and then they don't need the hypnotic agent anymore. But in general, I think insomnia for a pulmonologist is a little anxiety provoking, because we aren't treating it at all, really. And so, I think it's challenging, but there are some, like Emerson nicely presented, there are some very simple and easy things that you can do that can really make a huge difference. Not all these patients are you going to be able to fix, but there's a lot of them that, with some very simple questions and behavioral changes that you can make a big difference in.
Fantastic. No, and so Nancy, a couple of questions here. If you do home sleep studies, do you recommend them to be attended, or a home sleep study is never attended? What's your recommendation there?
Yeah, in the U.S., all of our home sleeps, I would say 99% of home sleep studies are performed by the patient. So, they typically will get some instruction or watch a video or some written instructions, and then they're sent on their way to do the home sleep test, and that's how they're performed.
Sure. And anything about oral myofunctional therapy that you would recommend to patients who do not want to use CPAP? Do you routinely recommend it for patients with moderate to severe OSA?
Well, the data on that would suggest that there's some modest, perhaps, improvement. In the U.S., usually if patients are anti-CPAP, end up sending most of them to get a oral appliance, to use oral appliance therapy. We find that is pretty adequate in a lot of patients, certainly those that have mild to moderate. And, occasionally some people that have severe apnea, it usually is beneficial and is better than doing nothing at all, right? So in the U.S., I guess we tend to push more towards oral appliance therapy than as a second step for most patients.
Sure, and you don't advise the tongue exercises to every patient. The oromotor exercises not so often. Okay. There was one study that showed that it reduced the AHI by 50%, wasn't there? Or?
Yeah, there are some studies that have shown some, like I said, modest improvement. I think it's reasonable to, again, it's not going to hurt, and it helps in some modicum of way for a patient to reduce their sleep apnea burden. I'm all for it. Just that, we tend to probably work on more substantial treatment than that.
I can understand. No, from a sleep expert center, I'm sure that's what would be recommended. Just that, and Emerson, on a question on insomnia, how many of your patients actually require a drug to treat their insomnia? What percentage would you think in your practice?
For the insomnia alone, it's a small number. Now, the data regarding combined therapies are actually quite promising. And by that, I mean there's some evidence to suggest that combining pharmacotherapy and behavioral therapy during a very controlled period and then tapering off of pharmacotherapy produces better results than behavioral therapy alone. I think that's an important area for future research. When people come to see me, particularly for insomnia, they're generally aware of my background and expertise, and so I see a somewhat select sample of complicated patients, as Nancy mentioned earlier. Now, that being said, there are times when I recommend that patients should consider or continue a medication. If someone is a chronic hypnotic user and they are in a period of high life stress, or if they are particularly stressed out during COVID, oftentimes I'll say to people, listen, this is fairly straightforward to come off of the medication. That doesn't mean I can guarantee that that we can do it in a week, but now's not the time. The time to discontinue a chronic medication is not right after you lose a loved one or have a job transition or any other major life stressor. Patients with particular psychiatric complexities, where they're taking a number of psychiatric medications, oftentimes those are patients where we want to be very, very cautious about recommending any medication changes because the risk is so high. We don't want to trigger manic episodes or depressive episodes or psychotic episodes, and so on and so forth. With those few exceptions, the majority of our patients, we don't recommend pharmacotherapy. Now, when patients are struggling with CPAP, as Nancy mentioned earlier, again, in a time-limited way, to make sure that patients have a positive subjective experience. What sleep psychology adds to the sleep medicine field, in large part, has to do with appreciation of the subjective experience. We make choices because of the way things make us feel, okay? And so if adding a hypnotic helps a patient feel better from CPAP and then makes it more likely that they'll stick with it,
Right.
why wouldn't we want to do that in carefully selected patients?
Sure. And if you had to choose a drug, there's a question, which drug would you choose? Is there anything safer than the rest or anything new on the horizon that you're excited about?
Well, I'll answer that based on the data. I think that that there are drugs with higher documented risk of adverse events. There are particularly at-risk patients. So, for example, the case I presented today is a 67-year-old man. I did that on purpose, obviously, because we want to prescribe very thoughtfully in older adults. Benzodiazepines should be avoided. Ambien in particular, among the Z drugs, has well-documented risks for falls and other adverse outcomes, particularly among older adults. I think that newer medications, Nancy, I'd be curious what your thoughts are. I think that there's promise for something like an orexin receptor antagonist that has a different mechanism of action that could reduce fall risk among older adults.
Nancy, orexin receptor?
Yeah, well, I think, zolpidem is one of, I guess it is the most prescribed hypnotic. It's been around for a long time. It does take bad knocks because, it does have, as Emerson noted, pretty well described side effects, adverse effects. But in part, I think that is related to the fact that it is so widely used. I think it's important to keep that in mind as you start to look at these newer ones. Those ones have a lot of promise. Lemborexant, suvorexant, they certainly hold promise. I think the usage, I should say, is pretty early right now. So we don't know. It hasn't been used like zolpidem's been used. But I agree, it does have a lot of promise. I've used it a few times. I can't say I have a lot of experience with it yet. So, I guess the jury's still out on it, but the studies, are pretty compelling that it's going to be a pretty good hypnotic.
Thank you so much, Emerson. Thank you, Nancy. We've had a wonderful session today. At least I enjoyed myself thoroughly. I hope you all enjoyed the interaction as much as I did. I would again like to thank our collaborators, which are the Sri Lankan College of Pulmonology, the Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and AFMAPAT from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, the Panama Pneumology Association, and the Yemeni Association for Respiratory Care. Thank you so much to all our collaborators, and looking forward to seeing you in Season 2, Episode 8. Thank you.